So
yeah, I'll try to keep it in frame. Yeah, here. If I rub it like this, just touch it, just a touch, and it starts to bend just a little bit. Actually, you can see that it starts to bend just a little bit. I'm gonna go a little slower. And then bends a lot. That's weird.
Wow.
All right, for the people in the camera, let's just do it like this. Boom. From the side. Social media magic. This is so weird for me. Oh my God. I can't even hear reactions. That's weird. I'll straighten it out like this. And then last time for the guys in the back. There goes nothing.
you know, a lot of people are freaking out right now, Mark.
I can hear a little kid. Well, how do you do that? I don't know. All right, guys, have a good lecture.
You're incredible, Mark. That was absolutely awesome.
All right, muting. Have fun, guys.
Thank you so much for that, Mark. And I can honest to goodness confirm that the spoon is not a prop. We've given him spoons in the past from different restaurants, different countries, and he has yet to disappoint. He's been able to bend every spoon.
Have a good lecture. I'm gonna mute myself now. Bye-bye.
All right, see you, buddy. Thanks so much for doing that. All right, we can jump back on video, guys. We got about 5 more minutes. How's it going, Manisha?
Hi, good. How are you?
Did you see the magic?
No, I didn't see
what
happened.
You missed it.
Oh, Mark. Hi.
Hi. I'm that guy.
I just logged in.
Oh, you missed a good show. I tried to record it a little bit, but we only got the last part of it.
Oh, okay.
Thank God.
Right.
Thank God.
Mian's left the building. He's
out. My God, that's it. He disappeared.
I'm scared.
Oh, that's awesome. No, thanks for sharing that, Mark. Honestly, that was definitely very entertaining. And as I said, you could probably do this for days, and everybody would be glued to the screens.
Maybe that'll be our next talk.
We already talked about it. We Mark on here.
We said what did we say? Magic with Mark, starting at 11 a.m.
No, at 11 a.m. every day.
I love it. Hey, Marky, how's it going?
Hi. How are you guys?
How are you?
Good. I missed it too. I think I just caught the tail end of it. I just saw the bent spoon. That's it.
Yeah.
Do over at the end. That would be everybody's prize for staying till the end of the meeting.
Yeah. Jamie said payments will be accepted at McCabe Denture Clinic.
for my grocery bill. Yeah.
Right. Exactly. Hey, Mian. Hey, Jeff. Anand. Azim.
Manisha, how are you?
Good. How are you?
Good. Very good.
It was great magic. I have to attest. It was amazing.
It's so much better live. You just don't
yeah.
appreciate it on the screen as much as you should, Mark.
Well, it's life. This is the way it is now.
I know, this is the new normal, right?
The new normal.
Because Mark, some people are always thinking, oh, he's probably doing some type of trick photography there, right?
Especially now. This is like, I could just reach over and produce anything. Here's an elephant.
At one point, everybody literally at the restaurant was just handing Mark spoons and forks to bend.
Okay, now we're going to have Steve is going to flex for us.
Yes.
I don't want to take your show,
Steve?
Jeff.
The long sleeves off, Steve.
I missed the magic. Is it Magic Mike?
Magic. Yeah.
Magic Mike? Look at this. Do I look like Magic Mike?
What kind of website is this?
Not that guy.
Is there a 1-800 number?
How's it going, Steve?
Yeah, not too bad. Sorry I missed yesterday's talk. How was the afternoon?
I missed yesterday's talk.
There's an afternoon talk.
You missed. Oh, hey.
Were you there?
Yeah, we thought you were talking about yours.
No, I missed that one too.
No, it was good. It was very, very good. It was very informative. We were saying earlier that the cast technique that Azim was teaching, we definitely should schedule a couple of hands-on training sessions once everything goes back to normal. It was very informative.
Yeah, that's good.
Thanks, guys. Yeah, it's definitely a game changer, man. Definitely.
Yeah. Is that your go-to procedure now?
That's my go-to, man. That posterior sinus cast thing is just so quick, so easy. It's you know, and you want to spread implants for locators, not worried about getting good spread. It's just wonderful. So yeah, I think I'm a very big advocate for that kit for sure.
Yeah, right on.
Use it for lateral window too, is he?
Sorry?
Use it both for the bump and lateral window?
No, they have actually, I don't do any lateral windows anymore. I don't need to with this kit, really.
So what do you need minimum? 3 millimeters? 2? Or you can with 0?
I've done it with 1 millimeter bone, residual
Really?
bone. But I mean, you want to start off with like 5 or 7 millimeters, but
Yeah, for sure.
yeah. So happy to share, guys.
You know where it hit home for me is that, you know when you're doing with the osteotomes, that clicking with, you grab a mallet and you're just, you're literally hammering away, and the patient, you got to walk them through, hey, look, you're going to hear some hammering and you're going to hear some of this, be careful, right? It's nothing to be worried about. But with this, it doesn't exist anymore, right? So from a patient comfort perspective, it makes a big difference for sure.
I've never been an indirect sinus left technique guy. I've always been a lateral window guy.
Mm-hmm.
And for the few cases that I have done with a bump for an extra couple of millimeters at most, actually, I gave a guy vertigo for 2 months.
Really?
Yeah.
Really?
So I didn't know that was a potential complication of the procedure. He advised me of that after he suffered the vertigo.
Wow.
So from using the osteotome, and I'm pretty conservative with it, I wasn't wrapping the heck out of the guy, and it actually lodged something in his inner ear, and he had vertigo. He couldn't drive for 2 months.
Wow. See, this is the first time that I even hear about that. And here I am
Yeah,
going about it like I'm in construction, right? I'm going to get the big hammer.
I use that thing very, very conservatively. So, if you're using that much force, you're too far from the floor anyway,
Mm-hmm.
right? So, I mean, if you're being too conservative on your approach and you're too far from the floor, then you need a lot of effort to bump it in. So
Absolutely.
if you're using too much force, you got to stop and think of where you are.
I've just seen so many doctors who are beginners who've done this so successfully, right? And we've even taken post-op CBCTs to check the lift and stuff. So it's just that easy and non-invasive, and patients love it. So something to look at for sure.
Absolutely. Now, Nazia asks, Azim, is there any way that we can view or see your presentation from yesterday, or how would you recommend us to watch it again, or for those who missed it? Is there any way that we can watch it again?
Yeah, it'll be posted on the aiceducation.ca. I'll type it in here. They're still working on editing it because I think I said a few bad words like one night stand and or something else.
God.
Oh yeah,
That's like my lectures. I don't even record my lectures anymore.
Mian's gonna keep it a lot cleaner, right, today? So yeah, it'll be there. I'll put it on.
Whatever comes out.
Well, it's Mona. Hey, how's it going, Mona?
Hey,
Mona.
How are you, Mona?
I'm hanging in there. I'm doing good. I'll tell you, it's easier to figure out a business in crisis than it is to homeschool 2 kids at home. So I just run to my office every time I can to figure this out.
Yeah, that's
God
awesome.
bless you. For all those parents out there, I don't know how you guys do it.
I don't know how people, the young ones, do it. Mine are a little bit older, but it's not easy. So we're hanging in there. I have a newfound appreciation for teachers. That's for sure.
Absolutely.
How are you guys doing up in Canada?
We're doing well. We just watched some magic, so we're doing everything that we can to stay entertained. So it's good. It's been good.
Crazy.
Where are you
We
located,
just
Mona?
found out that we are now to stay-at-home mandate till May 26th. So trying to figure out another 5 weeks of this.
This is really, so this is just, this is in Illinois itself? Or
Wisconsin, yeah.
Sorry, Wisconsin?
Yeah.
Oh, wow.
We'll figure it out. Yeah. Well, everybody's in the same boat, but
Yeah.
it's great to see you guys and have something to look forward to today.
Well, thanks for joining us today, and I hope you and the family and everyone around you stay safe.
Thank you. Likewise.
Perfect. So we're going to go ahead and get started. And if you guys don't mind to go ahead and mute your mics and your video as well. And I'm going to pass things on to our co-host today, Manisha Jindal.
Good afternoon, everyone. Welcome back. Looks like we have a great turnout so far. People are rolling in here. We're almost at 200. So remember, quick housekeeping again, like usual, for additional talks, you can go to DT Academy/webinars to register for future talks. Once you have logged in here and written your email, we will automatically email you the upcoming talks as well, but you can check that out. It's always updated. Remember, Vic is going to be doing his talk. Is this the death of dentistry? It's coming up on Monday. There are 2 sessions. One is at 10 a.m., one is at 2 p.m. And register quickly. I know it is definitely filling up, and get in there early so you get your spot. I think it's going to be a great talk from the preliminaries that I've seen. We will put up the registration link here, and it will be, I believe most of you would have it in your inboxes. We will send it out maybe one more time this weekend. And don't forget to visit the YouTube channel for Dentistry Disrupted, where a lot of these talks are available at your leisure. And I will pass it over to Hisham to continue. Mike, Kish.
Yeah, a couple of other housekeeping items that we're doing. Please make sure that you type in your full name and your email address, just in order for you to qualify for some continuing education points. The other thing that we also want to do as well, you will be receiving an email with the upcoming, from previous continuing education talks as well. One of the other things, as Manisha already mentioned, for housekeeping concerns, please go ahead and make sure that you mute your mics and also your video as well. And if you have any questions for Dr. Kwek during this lecture, please feel free to text them into the chat group, and we'll be more than happy to go ahead and ask Dr. Kwek those questions later on. We will also be conducting a few polls during this webinar, so please make sure that you stay tuned in and glued to the screen, because we will be asking some polls that we will require for you to go ahead and answer us. Our upcoming talk is, as Manisha mentioned, Vic Jindal's on April 20th. We do have 2 talks, one at 10 and one at 2. Our talk after that is going to be by Dr. Jeff Sumner, and that's on Tuesday, April 21st at 12 p.m. Dr. Sumner will be speaking on the next evolution of digital dentistry. And what I'm going to be doing here, I'm just going to be bringing in Jeff into this conversation right now. So I'm just going to unmute him and turn his video on. And Jeff, just to make sure that he's there. Jeff, can you talk to us a little bit about this upcoming talk that you're having?
I can. Thanks, Hisham. Thanks, Manisha. So on Tuesday after Vic, which is going to be a tough one to follow, of course. I don't know why they put me there, but anyways, I'm talking about the next evolution of digital dentistry. Now, of course, changing times. I mean, you know, if I were to talk about the next evolution a year ago, I'd be talking about Prime Scan. If I were talking about the next evolution even 3 months ago, I'd be talking about the Prime Mill. I was in Germany for the release of the Prime Mill. But these are changing times, and during these times, nobody wants to be spending $100,000, $200,000 on equipment. So I'm going to be talking about a different way that we can continue to move forwards with digital dentistry and how we can adapt to the times. And one of the big things, and I'm going to give you the big release here, is we're talking about using the equipment that you already have in your office, using the technology you already have in your office. And if you are going to buy anything, make sure what you're buying is smart. The one thing I would certainly recommend that everybody should have in their office very soon would be a 3D printer. And as we know, 3D printers are really reasonable, and you know, that will be a game changer for all of your digital practices. So I think that's the next thing to go, and show how many different aspects of dentistry we can use our 3D printer with. Everybody thinks obviously it's just ortho, but there's so many more. So we'll be talking about that. It should be a fun lecture on Tuesday. Looking forward to it a lot. So I hope you can join me.
Thank you so much for that, Jeff. And I'm going to pass it on to you again to go ahead and introduce our speaker for the day.
Great. Okay. Thanks everybody for joining. I am very excited about Mian's talk here today, and I'm honored and pleased to be able to present Mian today. I've known Mian for 27 years. We graduated together along with yesterday's speaker, Steve Diana, from U of T way back in 1997. Yeah, we're an old bunch here. Mian is my colleague, my business partner, my speaking partner, my mentor, but most importantly, he is one of my best friends. We talk and hang out so much that my wife and his wife call us boyfriends. Oh, is that your boyfriend on the phone? Yep, that's him again. Mian has taught surgery to so many GPs over many years. And a few years ago, we were probably a few drinks in, and we decided we were going to join forces and speak together. And I have to say, I've had more fun in the past couple of years working with Mian and Hisham than I've had in my entire 23 years of being a dentist. Mian is an international speaker and a key opinion leader for Dentsply Sirona, for Patterson, Vita, other companies. We were keynote speakers at Chicago Cerec Dental Symposium. Shout out to Mona there. Last year, we spoke at the national sales meeting for Dentsply Sirona about our vision for their company. We spoke at Pacific Dental Conference, not this year, thankfully. And we spoke at Dentsply Sirona World last year. That was quite a highlight. Mian is a numbers guy. I think you're going to see that today. And I have learned so much from him. He can look at the numbers of any practice and analyze them like nobody else. He runs probably one of the most efficient practices in Canada. Vic will attest to that. And he does it while doing amazing dentistry and still being one of the most generous guys I know. He gives back to his patients, his friends, his community, and obviously, as you're seeing today, our dental community. Usually I'm busting Mian's chops. I don't know what he's going to think of all this. I'm his accolades and everything. So I need to stop right now because his head's going to get too big. Anyways, please welcome, in the comfort of your own home and in front of your own computer, Dr. Miyen Kwek.
Thanks, Jeff. Thanks so much for the kind words. Honestly, really humbled by everything. And thanks to everybody for being here today. Can everybody see me? I'm not sure if I'm supposed to be turning my screen on soon, Sham. But, you know, I want to thank, sorry?
We can hear you.
Okay. So I just wanted to thank everybody here for, you know, I know it's been like, what, 4 or 5 weeks. We've been sitting here at home, dealing with all this COVID stuff. And, you know, we're trying to learn, do the best we can. And after a while, I'm sure learning, after 4 or 5 weeks, we're all tired of sitting down and learning and being online. And, you know, I appreciate, what, 250 people now. It's amazing that on a Friday afternoon, we still get these numbers coming in. So thank you, everybody, for taking the time to join us. And, you know, I'm listening to all these talks this week. Amazing speakers like Dr. Azim Sheikh, Dr. Kevon Abazadeh, Dr. Stephen Diana this week. And it's all in line with what I do. It's surgery. I love it. And for me, in the past 20-something years, you know, I do a ton of surgery. I teach surgery. And when I listen to these guys, I'm like, wow, you know, I really have a lot to learn still. And I think it's for us, even as much experience as we do have, we all need to take a step back and kind of check our egos at the door and to be able to be open-minded and learn things from others. And I want to say thank you to Dr. Hisham Shurigan for being able to create this online platform where the guys who are seasoned at this can share our knowledge, and all the dentists who are joining can actually hopefully take something from it. So Sham, I just want to say thank you to you and team and Dentistry Academy and for all the speakers who have devoted their time and efforts. So I just want to say thanks. And without further ado, I think we can probably start. So where are we here? Let me share my screen. So Shannon, let me know whether or not this works. 1 second. Can you guys see?
Yep, we're good.
Is that working?
Perfect.
Good to go. Okay. All right, so today's talk is going to be thriving with technology in any economy. And usually, for those of you who have seen myself speak up on stage, usually I'm sitting down or standing up with Jeff with a glass of wine or something. But today I'm going solo. 1 sec here, hold on. So Jeff is out of the picture today. It's just me and my own home. All right, so I want you guys to think about a hypothetical practice. Okay, so think about this office. What if you virtually had 0 turnover of staff? Your staff are happy. They're free to order whatever they want to order. And at the end of the day, you don't really stress about costs. Okay, so it sounds pretty good. So let's take that same office and take it a step further. So what if in the same office, you pay your staff at the upper percentile, in the top 90% in your region, yet your hygiene produces less than the average? On top of that, you charge less than the fee guide. You're a couple years behind. On top of that, you discount at least $1,000 of dentistry a day, meaning that you give it back to your patients. Take it one step further, your sundries are 50% higher than the average. So I want you guys to think about that practice. Okay, just kind of put it in the back of your minds right now. In Ontario, and I'd probably say most of Canada and the States, the average practice overhead, and this is 2018-2019 data, is about 63%. And an efficient practice is in the low 50s. So I want you guys to think about that office I was talking about, where everybody's happy, they order what they want, yet you discount dentistry, your hygiene is less than the average, and you give away dentistry and your son
in the shower. But you don't go in the shower.
So what I want to find out, guys, so Sham, if you could kind of put up the first poll. I want you guys to let us know, let me know, what you think the overhead of that practice would be, based on everything I told you guys. Sham, let me know when you have the answer. Or will I be able to see the answers? I don't know.
You should be able to see the answer. We're just going to give it another 15 seconds if that's okay. We currently have about 169 respondents.
Okay. And Sham, how am I supposed to get rid of this thing on my screen?
You can just drag it off of your screen.
Oh, there it is. Okay, good.
All right, Mian. So out of the people that responded with the percentage of overhead, the 22% said 65 to 70.
Yep.
Close to the number 2 was 50 to 60, and that's 20%. And then tied for last was 11% was 50 to 55, and over 75%, 11% said that as well.
And 70 to 75 is what?
75 was 11%.
Okay, so most of the people are where? In the what? In what
most
bracket?
of the people are in the 65 to 70.
Okay, all right, perfect. Thanks, guys. Okay, so what if I told you that the practice I was describing was actually my own? Okay, and what if we said that instead of the 65% and up, it's actually in the low 40s? And what if we took it a step further and we added back the discounts and we charged the regular fee guide like most dentists would? What if I said that if you actually put that back in the equation, it's actually in the low 30s? So the topic here, guys, I'm not here to wow you. I'm not here to impress you. I'm not here to think that, hey, I'm all great in life. That's not the point. The point is I'm here to impress upon you that it's possible. But the question is, how? So here's the answer, plain and simple. Success is the uncommon application of common knowledge. So everything I want to share with you guys today, the great thing is that you guys already know the answer. It just kind of tucks somewhere in the back of your mind. I want to bring that knowledge in the forefront today. And if you can apply it in just a little bit of a different way, you actually can change everything. Okay, so that's the goal today. So as dentists or students in dental school, we're all taught to think a certain way through school, outside of school, and even with our colleagues, courses, what have you. We're all taught to think the same way. But I'm going to challenge you all today. Maybe there's a different way to think. Maybe there's a better way to think. Okay, I'm not saying that my way is the way, nor is it the better way or the best way. But it's just a different way of looking at things to open your eyes to the possibilities. Okay? Unfortunately, this is the time we're at. And we need to take the time to think about what's going on in life. And the great thing is, take advantage of the time with your families, your friends, online, unfortunately. And take the time to digest the information that your colleagues are trying to share with you. Because when we go back to work, sooner than later, guess what? Hopefully you have the tools to be able to use to advance yourselves way ahead of the curve. So we're going to talk about thriving with technology today. So how do we do this in our normal everyday lives if we're stuck at home? Think about this. For those of us who work out, we can't go to the gym, we don't really go outside, so we find a way of using technology to our advantage, using apps, going online. Let's say if you're members of Good Life Fitness, being able to go on classes online with others while you're at home. If we like to go out to eat, guess what? We use technology to bring technology to us, so the food gets delivered to our homes. Our kids, we have virtual classrooms at homes now. They don't have to leave the house anymore. And whether or not we're buying groceries or things from Amazon, it's all done with technology. With our friends, we can't see them physically, but we see them virtually. So we have apps like Zoom, which is phenomenal. And to be able to do CE, this is the current way, unfortunately. But is it possible it could be the future? It could be. It's a more efficient way of learning. We don't have to leave. We don't have to take time to travel, stay overnight, stay at hotels. Dr. Miyen Kwek talked about this a couple of weeks ago. And it was amazing because she talked about during virtual consults, she had the opportunity to do virtual consults with patients prior to COVID, new patients who she met online, and the rate of which they come into her office all of a sudden dramatically increased. And chances are, because she created a relationship with them prior, her success rate and her acceptance rate already is in the 90 percentile. She's going to basically boost it to close to 100. So that's where technology is going, guys. So you got to look at, see, okay, no matter what the condition or the economy, we have to take advantage of the tools that are in front of us and figure out how do we use that for the future. Everything with dentistry, this is what I think about. Whether or not you're buying new materials, new technology, or thinking about a new technique, it has to be the 3 Ps for me. Predictable, practical, and profitable. Okay, I'm going to go through each one of these. Predictable. Is what I'm using, is what I'm buying, is it predictable? Is it going to give me a consistent result all the time? Okay, practical. I want to make sure that whatever I buy or use, I don't use it once a month, once a week. I want to use it every single day or multiple times a day. And profitable, I want to make sure there's a return on my investment. So when we're talking about technology, let's say, for example, if you don't have a pan machine and you buy a digital pan, there's a fee or a code you can bill for it. So you can actually quantify how you're going to pay it off. But then there are things in technology, let's say like a scanner, you can't bill for it. So how do you actually quantify it? And that's what we're going to talk about today. For those of us who have gone through the process of going from charts to a chartless system, we buy computers for what? Because it's cool? Not really. It's probably more organized. It keeps things cleaner. You have less paper, but it's more efficient. But a lot of us, we buy technology and we don't see the value of what we're paying. We're paying $10,000, $20,000, $30,000 of computers and software, but we don't see return on investment. So think about this. Let's say, for example, right now, if you have a hygiene patient that cancels, you have a 40 or 50-minute slot that's open and available. What do your front desk do? Guess what? They basically go on your computer system. They basically find out who's available. They have probably a short notice list or a list of patients from a couple weeks ahead of time, and they try to call them one at a time and drag them in and see who's available. Or you could take the advantages and the advancement of technology. Now, software applications can find out who, based on your parameters, who the computer can basically text or email, send out the messages, and basically whoever sends the message back first, it auto-populates. So if you think about it, let your software do the work for you. It's more efficient. Therefore, your staff have all the time in the world to do other things. So you have to be able to quantify that. The problem with technology is that it costs a lot of money. So the goal for today is not to try to sell you on technology. It's not to try to sell you on anything. It's to basically give you the tools to look at things a little bit differently, to make sense out of things. So down the road, should you ever decide to invest in something, you have a different set of eyes to look through it at a different way. All right, so a couple things. The average dentist produces about $400 an hour. I think it's the same in Canada and the States. And so this is going to be my reference point for the entire talk, okay? The other thing too is that the rule of return on investment. If you're buying equipment, technology, my rule is that you want to be able to pay it off in 3 to 5 years at the most. If it takes longer than 5 years, either you're not using it enough or it costs too much to be able to purchase. And a lot of times technology will evolve, right? So if you buy something, and let's say 5 years down the road, the technology advances and changes, and then let's say you have like 7 or 8 years to pay it off, now you're paying off old technology. So you really want to pay it off in under 5 years. So that's the parameter of what I want to stick with for today's talk too. So let me give you an example. When we think about going from film to radiographs, a lot of us look at it and say, wow, you know what, I'm spending $20,000, $25,000 to change it, but yet I'm not making any more money because I'm still doing the same thing. I'm still taking the same number of x-rays. But let me show you a different way of thinking, right? So we all think one way, is that it's not an investment because we're not paying it off any faster, because that doesn't make any sense. We're just still spending more money to buy technology that we're not billing more for. So let's show you a different way of looking at things. So for example, and I'm gonna use very conservative numbers so it can apply to everybody here. Let's say, for example, you take 10 radiographs a day in your entire office, a very conservative number. And let's just say to go from film to digital x-rays, you're saving 1 minute each. We all know that going from the film to digital, you're saving 4 minutes to 6 minutes, right? But let's just use 1 minute as a very conservative number. So every day you're saving 10 minutes. 5-day work week. And let's just say that you're taking 12 weeks off a year. Okay, most of us don't, but I'm gonna give you a very conservative number. We're taking 12 weeks off a year. What does that equate to? Over time, 33 hours. So when you quantify it, based on the average dentist billing $400 an hour times the number of hours, based on the time savings and very conservative numbers, this is what you're adding to the equation. So if you can see here, based on a 1.5 to 2 years, you've paid everything off. And every single year thereafter, guess what? You've made that much more money. Why? Because you saved time. So that's a different way of looking at things. The idea is I want to help you guys launch your practice with technology. Okay, but just because you have technology doesn't mean you're going to make any more money. You have to understand how to use it and how to be efficient with it. And once you understand the efficiencies, then you understand how to be profitable. Okay, so we're talking about dentistry. You know, dentistry is a healthcare field, but it's also a business. So as a business owner, we all want to be as profitable as possible. However, with that said, guys, just make sure that this comes first and foremost. Okay, I can't emphasize this enough. We all have to make sure we take care of our patients the right way. And I guarantee you, and I'm sure a lot of my colleagues will say the same thing, if you take care of people the right way, the money will come. Okay, but this has to be at the forefront of everything. So I want to make sure everyone understands that this comes before all else. All right, let's continue. So technology is an expectation for our patients. I mean, they know what you have and don't have at your office. This is one of those times in this generation where it's not good to be old school anymore, okay, unfortunately. So where is digital dentistry today? It's not just about having digital x-rays or having a chartless office. Now it's about fully integrated technology. So what does that mean? So it means that you have different technologies communicate with one another. It's almost like when you have Apple products, your iPhone, your MacBook, your Apple Watch, your iPad, everything totally connects. Before I used to have a BlackBerry phone and I used to have a MacBook. And even though connected, it didn't really fully connect in the way that I needed it to. So with CAD/CAM, things have evolved. There are many systems out there. Cerec is the most common one. So Cerec, E4D, Strom's coming out with one, Ivoclar's coming out with one, where everything connects together. Things are evolving. Then we talk about connecting CAD/CAM and cone beam for guided surgery. So for example, let's say if you have tooth number 36, and in the States, it's tooth number 19, I believe. So what you do is you scan the arch on the bottom left, and you basically digitally have the tooth fit in. Okay, so you basically create the tooth virtually in form and function, and then what you do on the upper right side is you take a cone beam of that patient, and you merge the CAD/CAM and cone beam images together, so you can actually design an implant based on the final restorative outcome. So you want to have a screw-retained implant crown. It allows you to be able to design or create a guide that you can either mill or you can 3D print. So at the end of the day, you actually have everything figured out before you even freeze the patient. That's where dentistry is right now. Then you talk about combining the two systems for guided endo. Same philosophy. To be able to have a guide to be able to put on the patient's mouth or teeth, so you can actually access the canals without perforating and know exactly where the orifices of the canals are. Combine the same technology for airway. Be able to create an appliance to move the lower jaw protrusive to open the airway up. And finally, to be able to have digital ortho solutions. Now you can scan patients and have these STL files come back from the companies so you can 3D print models and make your clear aligners. This is the biggest boom in orthodontic history. This is what it is. And right now, even though we're not doing this, as soon as we get back, this is gonna be where everything's gonna go. So the question is, where do you start? So Sham, I'm gonna ask you to ask the second question. I wanna see who in the room has what technologies, and whether or not you're an associate or you're still in school. Obviously you're not gonna check off any of the boxes, but if you're working at a practice that has the various technologies, please just check off all that apply, okay? So I wanna understand my audience, so it helps me to know or emphasize one thing versus the other. And guys, if I'm going too fast or if anything's happening too quickly and if I lose you guys, if you can just message Dr. Shurigan, that'd be great. So at least, Sham, you can let me know if I need to go over something or slow it down a bit.
All right, man, we have about 56 people, 56% of people have voted. I'm just going to wait till it gets to 60, and then I'm going to go ahead and show everybody the results. Couple more. Okay, I'll stop it there. All righty, so can you see the results there?
Oh.
I'm going to go ahead and share them with everybody. So for those who can't see it, what technologies do you currently have in your practice? 98% have digital radiography, 48% have digital scanners, 37% have mills, 24% have CBCTs, and only 8% have 3D printers.
Amazing. You know what? And Sham, what's the age range of who's actually online? Can you tell me now, or do you know?
The age range is roughly around 24 to 34 years of age.
Amazing. Okay, so obviously this is a very this demographic in this room is younger, which is great. So the numbers in terms of what we have is higher, which is phenomenal. So congrats, and my hats are tipped off to all you. Okay, so let's continue here. So when you talk about technology, we have to make sense of it because it costs a lot of money. And so for those of you who already have the technology, I apologize, and I'll just kind of go through this. So just bear with us as we kind of get through this next stage. Okay, so let's make sense of things. So at the end of the day, when you're talking about fully integrated technology, everything starts with CAD/CAM. So how do we think? Right, as dentists, we think that when we're buying a scanner, we think especially if it costs like $30,000, $40,000, $50,000, and that's a lot of money. And when you think about taking an impression, if it costs you like 40, 50 bucks per impression, for example, you need to take 1,000 impressions to be able to equate to the cost of the scanner. That doesn't make any sense. So why would we buy it? So how should we think? So let's show you why scanners make sense. So let's talk about the traditional workflow. For all of us who we've taken polyvinyl siloxane impressions, let's just talk about tooth number 37 we're going to crown. In the States, it's tooth number, what, 18? Am I right? Yeah, 18. Okay. I know Mona's here. So what do? So we give a block first, right? And after we give a block, we take a sectional or full arch impression to be able to fabricate a lower temporary afterwards. Then we do our crown prep. Then we place retraction cord or paste. And then we take our final impression, 3, 4, 5 minutes, depending on how the working time or set time is. And guess what? A lot of times we take another one. And sometimes we take 3 or 4, and we've all been there. I've been there many times, where there's subgingival margins, there's bleeding, there's pulls, there's bubbles. And even though a lot of us take triple trays, we still take a bite registration. Why? Because we're not 100% sure whether or not that bite was accurate, especially when the patient's been open for like 30 minutes, 45 minutes. We make a temporary crown afterwards, and somewhere along the way, usually at the beginning of the appointment, you pick your shade. That's a traditional workflow. And 1 to 2 weeks later, we get this. We get a crown that maybe 20, 30% of the time, it doesn't look the greatest. And so we either have to send it back to the lab, which sucks. And a lot of times, or 20, 30% of the time too, the crown doesn't fit. So we have to adjust contacts or occlusion. And there's sometimes we have to send the crown back to the lab. So again, we're wasting a lot of time and money. So CAD/CAM's evolved a lot in the past 20, 30 years, to the point where now there's so many scanners on the market. So the question is, what do you buy? You know, I'm not here to knock any scanner. I think that every scanner has its place. You have to think about what makes sense for you in your practice. It's almost like buying a phone. iPhone, Samsung, LG, whatever makes sense for you, whatever software makes sense for you as well. Look at costs, look and see whether or not it's just a scanner, whether or not I can integrate with a mill. All these things are variables that you need to look at. So let's show you the same thing, but in the digital workflow. And I'm gonna show you what I use as the prime scan, and we'll do the same case, tooth number 37. Okay, so I give a block, and right away, we're gonna start scanning. So this is scanning in real time. And so the idea is the prime scan has upgraded compared to the previous generation, the OmniCam. Watch what happens to the tissues, the tongue and the cheek. It basically scans it and it disappears. Okay, you do the same thing on the upper arch. And so the technology has evolved so much that it recognizes what tissue should be there and what shouldn't be there. So even if your gloves are in the way, it knows that it shouldn't be there, so it automatically deletes it. And so the idea is that you're doing all these scans prior to doing the prep because you're waiting for the patient to freeze anyways. And here you can see the patient needs another crown on top here as well, okay? And then what you do with the bite, and this is what Dr. Goth-Siu talked about a couple weeks ago, when you scan the bite, you physically can see the patient in occlusion. When you're talking about doing PVS impressions or when you do a bite registration, you can't even tell where the patient's biting. So this way, with digital, you see the patient in occlusion before they're even fully frozen. And when you do the final impression, you basically virtually cut that tooth out. And instead of taking 3, 4, 5 minutes for your PVS impression, or possibly having a second one that you have to take, and possibly having a bite registration, the final impression is actually done in 10 seconds, all right? The great thing with Prime Scan, it actually draws your margins for you. And in terms of being able to design the software over the past 20, 30 years has evolved so much that you're maybe tweaking your crown design maybe for like a minute, and you're ready to fabricate it and put it in the mill and make it. So we talked about this reference point of $400 an hour for the average dentist. So with digital scanning, your prep times are reduced by 5 minutes. Why? Because instead of having your 3 to 5 minute initial PVS impression, or possibly a second one, and maybe even the bite registration, it took you 5 to 10 seconds, right? So on average, definitely and conservatively, you're saving 5 minutes. On top of that, your insert time's reduced by 10 minutes. So why is that? When you use PVS, what happens? There's so many sources of error. So for example, there's distortion, probably in the material, distortion in the tray. There's patient factors. The patient can bite on the tray. The patient can open and close their mouth while they're biting. They can have bleeding, they can have saliva, they can have bubbles. All those things play a role. And then there's the lab. The lab has to pour the impression up. And so all these issues create sources of error. When you're dealing with scanning in digital, there is no reason why everything should be exact. As long as your lab knows the parameters, your crown should fit like a glove every single time. So realistically and conservatively, your insert time is reduced by 10 minutes. It really only should take you 10 minutes, but if you have a 40-minute appointment, you should take 30 minutes. If you have a 30-minute appointment, you should take 20 minutes to insert. So you're saving 15 minutes of time based on a $400 an hour rule. Okay, so you're saving or making $100. So when you go from polyvinyl siloxane to a scanner, based on the average dollar per hour, and the average number of crowns that dentists do are 10 a month, you're saving or making $12,000 a year. Based on 20 units a month, you're making $24,000, 40 units a month, $48,000. But a lot of us, and I'd probably say that based on the numbers that I'm seeing with you guys who are very tech savvy, you're probably billing more. And some of us are billing in excess of $1,000 an hour. So this is where the numbers hit home. If you're anywhere in between these two lines, you've made a return on your investment. And so you paid everything off in under 5 years. And we're talking about the Prime Scan. It's probably the most expensive scanner on the market. So I'm showing you numbers that you can actually pay off the most expensive scanner out there. Mind you, it's probably the fastest scanner out there and most accurate. But again, maybe you get what you pay for. I don't know. I don't really know the other scanners that well. Let's take this up further. What if you're the lab? I think Sham talked about 37% of you guys have mills. Fantastic. So for the other 63% of you, what if you're the lab? The great thing is that you're in control. You control all the parameters, the margins, contours, context, and shade. For those of you who don't realize it or don't know what this is, those 3 little blocks there on the right, those are blocks that you put in the mill. After it carves out the crown, then you put those in the oven. The oven will help to crystallize it, turn it really strong, really hard, and then it puts it into its final shade as well. So when you're in control of the parameters, you can set your parameters to however you want to set it. Your occlusion, your contacts. So let's say my contacts, I want it to be a certain way compared to another colleague. I can set it however I want, so I get a consistent result every single time. I can truly control the snap of the floss, and I don't have to worry about things changing ever. This is the problem, the cost. It's not cheap. It costs 200 grand for this type of system. So how do we think? Right? As dentists, we think, you know what? I don't have that kind of time to make this. I don't want to be the lab. So how should we think? So maybe there's another way. Maybe time is money, right? Time is money. And so let's just find out how to use technology to save time and make more money. So let's make sense of this with return on investment. So when you're talking about a full system, the ROI is a combination of time savings plus now you're the lab. So you actually have lab profits. Let's break it down. So time savings with digital scanning and milling, your prep time is now reduced by 10 minutes, not 5, but 10. Why 10? Because now you're making, now you don't have to worry about making your temporary crown. So that's an additional 5 minutes you've saved. On top of that, we talked about inserting your insert time reduced by 10 minutes. So total time savings is 20 minutes. So based on $400 an hour rule, you're saving, you could be making an additional $133 an hour. So when you, and also on top of that, sorry guys. So based on 20 minutes time savings, sorry, on the right side there, this is what you're adding to the equation every year. Let's talk about profits. So block costs are about $40 in Canada. Lab fees, $330 to $350 for the most part. So you're net profiting about $300 a unit. So depending on how many units you do a month, on the right side, that's the profit you make per year in addition. So when you put it all together, this is what you get. So the complete return on investment based on the average dentist doing $400 an hour, based on the average number of crowns, 10 crowns a month, you're adding the equation $52,000 a year. If you double it, 104,000. If you do 40 units, now you've paid it off. But again, chances are a lot of us here are billing more. And so you add these numbers into the equation. And so for anywhere in between these two lines, you've paid everything off in under 4 years. Not 5, but 4. And the great thing is that after you paid it off, the number on the right side there, that's what you're making in addition to what you're already doing year after year. Okay, so a lot of you are going to say, listen, you know what? I don't charge that for the lab because I'm very competitive and I want to be competitive because my patients are trying to find crowns or whatever for the lowest price. So I need to charge less. So I need to also find a lab that's going to charge me less. And so my profit's going to be less, right? That's what a lot of us are thinking. So this is just my opinion, and this is what I really believe. If you're always going to be worried about the cost, especially patient costs, and it's fine to be able to worry about that, but if you're always chasing the bottom number, at the end of the day, who's actually doing more work? Are you going to be doing more work because you've chased the bottom number? Or would you rather do something different? And so what I'm saying is that instead of being worried about costs, provide something to your patients that gives them value. If you can give value to your patients, and if you give the patients the perception that you're doing something that another dentist can't do, guess what? They're not coming to you for the cost anymore. They're coming to you because you're doing something that they can't do, that someone else can't do, and so you've given them value. And if you do that, guess what? You're not going to lose your patients because they're not coming to you because of the bottom price you're charging. But let's just say that I'm not going to convince you, which is fine. And let's just say that you're going to say, okay, I'm going to make $150 of profit per crown and not 300. Well, let's put those numbers in the equation again. This is what you get. And if you're anywhere in between these two lines, you've paid everything off in under 5 years. The very top line, what's the number? You've paid that off in under 6 years. Okay, but this is one thing I haven't talked about yet. All of this. I didn't talk about all the costs all the costs for everything we need to do with regards to the temporaries, the final impression, all the materials, temporary materials, adhesive, trays, bite registration. We can talk about all that yet. And that costs a lot of money, guys. Even at the most minimal conservative numbers and doing the minimal number of crowns, this is what you're spending. So when you add this back in the equation, even if you're charging $150 or profiting $150 per crown, now that top number, now you've actually made a return on investment in under 5 years. These are the excuses we make for ourselves of why we don't want to invest, and that's okay. These are actually my excuses. At the end of the day, this is what we all tell ourselves, why we don't want to invest in technology. And it's funny, you guys are hearing me today, and you're hearing me say 10 crowns, 20 crowns, 40 crowns. You're like, this guy's out to lunch, right? I don't do that many crowns. There's no way in heck I can do 20 crowns or 40 crowns. So remember I talked to you earlier, the success is the uncommon application of common knowledge. And I said that you know the answers. Okay, so I'm going to tell you something that you already know, but it's kind of tucked in the back of your mind. I'm going to bring it to the forefront again. So the secret is this. When you're excited about something and when you enjoy what you do, guess what? You do more of it. So think about our lives. For those of us who enjoy going to the gym, who enjoy traveling, enjoy doing hobbies, what have you. Whatever we enjoy, we do more of it, right? That's the common thing in all of us. And if you think about our offices, it's the same thing. So for example, for myself, I love doing surgery. So guess what? I do way more surgery than my colleagues because I love it so much. For those of us who love doing cosmetics, and this is Dr. Jeff Sumner's case, he loves doing aesthetic dentistry. He does more aesthetic CAD/CAM dentistry compared to anyone else I know. And as you can see here, he's great at it. He's a master of single anterior restorations. You can't even tell which tooth it is. And so he does more of it. We talk about orthodontics. And my business partner, Dr. Miyen Kwek, he does a ton of ortho because he enjoys it and he's great at it. Dr. Zoom Sheikh, Dr. Steve Diana, Dr. Steve Chang, and myself, we love doing implants. And so we do more of it compared to our peers. And with CAD/CAM dentistry, digital dentistry, whatever you want to call it, it's the same thing. And so let me kind of give you my own personal story. So hopefully people who are sitting on the fence, who are not convinced about things, and that's okay, I'm not here to convince you, but let me tell you my own personal story. So I'm actually a new user. Okay, I jumped on board just a little over 2 years ago. And the reason why I jumped on board wasn't because I thought it was cool, or wasn't because I thought I'm gonna make money and it's efficient. If anything, I thought this is really inefficient compared to who I was speaking with, because it takes a lot longer to make, so it didn't make any sense for me. But the reason why I jumped on board is because that when I actually saw the technology 2 years ago, compared to in the past when I saw it before, the technology 2 years ago, I was like, okay, you know what, it's finally here. And so I had a choice. Either I wait to jump later on when my neighboring dentists all have it, and so all of a sudden I'm forced to do it and forced to jump in, or I could take advantage of buying it now and figure out all the kinks in the system and figure out how to actually make it efficient and profitable, because that's what I do. I'm the master of efficiencies. That's what my strength is. And so I jumped on board. And these are my numbers before. I was the average dentist. Okay, I was doing 10 a month pretty much. And if you ask me, was I interested in doing crowns? Do I like doing crowns? The answer is absolutely not. I thought crowns were boring as can be, which is why I was the average guy. So when I jumped in on purchasing CAD/CAM, all of a sudden I was like, wow, this is actually pretty cool. This is pretty exciting. And I started enjoying that aspect of dentistry more. And so when I said, when you're excited about something, when you enjoy what you do, guess what? You do more of it. 3 months later, I doubled my numbers. 4 months after that, we hit 40. And this doesn't include the implant crowns that I do. And I place about 300 to 400 implants a year. You know, unlike the masters like Zim and Steve Diana and Steve Chang's of the world, you know, I do place my fair share, but you know what? That didn't include those crowns. So when you talk about the 20 and 40 units a month, and these numbers are out of the equation or out, you know, the way up there, I thought there's no way in heck anybody's gonna tell me that I can do that. But like I told you about the secret, guys, find it in yourself to understand how to think differently. Don't set limits for yourself. Because as dentists, we think, you know what, we're setting limits. Don't set limits. How should you think? Think about this. If I can do it, and I've done this just recently, and I'm just an average dentist, just like, and I'm no better and no different than anybody here. But if I can do it, everybody in this room can do it too. It's just how you need to think about things to advance yourself, so that you take your platform and you bring it to a much higher level. Let's talk about the capabilities. Okay, and after CAD/CAM, we're gonna move on. So I wanna show you things that CAD/CAM can do that traditional polyvinyl siloxane can't, or definitely struggles with. So think about this. If you're actually taking impressions of, let's say, 2 crowns, 4 crowns, 6 crowns or more, how many impressions do you need to take with polyvinyl siloxane, and how stressed are you? What if you're doing 14 crowns all at one time? So this is one of Dr. Jeff Sumner's cases. He's gonna be talking to this more on Tuesday, so definitely tune into him. And this is actually a case that he actually presents on Cerec Docs, and it was published recently in the past month. So I encourage all of you to take a look. This is him scanning with a prime scan, 14 crowns, stress-free. You're not taking 1, 2, 3 or more PVS impressions. He's taking impressions of 14 crowns. If he doesn't like the way that any of the margins look, he can rip prep one part of the margin, virtually cut out that part of the prep, and rescan it in like 2 or 3 seconds. But literally, within 30 seconds, this whole impression is done, right? And that's it. Very stress-free. So he goes from here to here without stress. And so just watch this next Tuesday. He's gonna kind of go through his case a little more. Another case, what do we all hate doing with crown and bridge? And I guarantee you that every single person in this room is gonna agree with me, this is the worst possible type of crown to do. It's this, right? Tooth number 1-6 in the States is tooth number 3. Who wants to crown this? Well, you know what? It doesn't look so bad right now. How about now? It's the abutment of a partial. This is the worst type of crown to do, guys. When we send this to the lab, do we ever get it back and the crown fits perfectly and then the clasp and the denture fits perfectly? Absolutely not. This is like a nightmare for all of us. So let me just kind of show you what we do. So this patient's 85 years old. She's not worried about the margins or anything like that. She's just worried about the tooth breaking. So think about this. With polyvinyl siloxane, how are we going to take the impression, right? We put light body in, and then we see the denture on top. And then we put heavy body in a tray, and we seat the tray on top of the denture, hoping to God that the denture doesn't move when we seat the impression. We pull the impression off, we send it to the lab, but guess what? The patient needs the denture back, right? They need the denture back right away, so you get the denture back within a day. But the problem is that the lab needs the denture back again to finalize the contours for the ceramics. So when it all comes back, does it fit? Of course it doesn't. And we're all stressed and struggling with this every time. It's the worst kind of crown we can do. So what do we do with digital dentistry? So with PrimeScan, what we do is we actually draw a line saying that this is what we want to copy. We want to draw a line to copy every aspect of the tooth that the clasp is going to sit on. And so we're drawing a line apical to where the clasp sits, on the buccal and on the lingual. That's where the clasp is. And so what we do is we have the software just copy what was there before. We're not actually designing anything. The software is actually replicating what was there. So within the hour, the patient never leaves the room, never leaves a denture at the office. This is the lingual clasp. This is the buccal and the mesial. This is how accurate this stuff fits. I am not stressed out at all. I'm not worried at all. The patient leaves stress-free within an hour. That's digital technology that will hands down beat PVS any day. One last case, and then we're moving on. I want to show you something that CAD can do that PVS is going to have a very difficult time replicating. So I had a patient came in about a year and a half ago. And he came in, and he's one of those diva patients, and we all know who they are. He owns a couple car dealerships. And he says, you know, doc, my bridge is loose. So we take a pan, and what do we see? So tooth number 2-3 in the States, tooth number 11. See recurrent decay. I didn't know whether or not we can salvage the tooth. So we went over the options, right? The patient said, no, I don't want implants. I don't want a partial. I want another bridge. But he also had 3 stipulations for me. He said, number 1, I want it to look exactly the same as what I have right now. I want the same aesthetics. Number 2, I want a couple shades lighter. And number 3, I'm leaving for Florida in 4 days. And so you hope that you have a great relationship with your lab, be able to pull something like that off. So this is what we did. Okay, we did an upper scan. This is the Omnicam at the time. Did an upper scan, we did a lower scan, and we did a bite. Notice that this is the only place of posterior contact. Okay, on the other side, it's open. So everywhere else, he was occluding in the anterior segment. So thank God we were able to salvage that tooth number 2-3. We did endo, built a post up, built it up, and we basically prepped from 5 to 5, premolar to premolar. Remember though, this is the only place of contact in the posterior. So if you're doing PVS, think about how you're actually going to be able to take the impression and reproduce the bite. It's not that easy. So let me show you what digital does. So with digital, these 3 teeth I didn't touch before and even after I prepped. So what I was hoping to do was hoping to ask the lab, say, okay, listen, I want you to superimpose those 2 images over each other. So if you have the occlusion from the pre-op, then the post-op scan, you should still be able to figure out the occlusion. And that's exactly what they did. So 4 days later, we inserted the bridge. It fit like a glove, contacts, occlusion, everything was bang on. Patient loved it because his aesthetics were exactly the same. He had a couple shades lighter. I thought it was too light. And he was done in 4 days. Let's take a side shift now. Let's talk about something different. Let's talk about material technology. So this is something that we all struggle with, right? How often do we have the shade being off? And why is it off? So kind of going back to school, hue value chroma, it's because the value is off. That's the reason why, for the most part. That's what labs generally say. And I probably say for the most part, 20–30% of the time, this is why it's off. Once again, how do we think? And how should we think? Every dentist in the world uses the Vita Shade Guide. Right? Vita is the shade company of the world. And the problem is this. We all have the classical shade guide. Understand, this was invented back in the 1920s, 100 years ago, guys. And so I'll give you a quick history about this. The German dentist that invented it way back when had 16 of the most common shades. And when you put those 16 shades on a 3D graph of hue, value, chroma, this is what it looks like. And so most of the shades that we use are in this segment, a small portion of that 3D graph. 70 years later, Vita invented the 3D shade guide. And a lot of us have heard of it. It's confusing because we don't know what to do with it. But Vita 3D shade guide, what it is a scientifically proven way of systematically being able to pick a shade and to systematically be able to reproduce the shade of the lab. So when you have a 3D volume, all the shades span out the entire volume. And if you want a shade in between, you know what? The lab can reproduce it because it knows the hue, value, and chroma. So this is one of those take-home slides, guys. You know what? For Vita, because it's the shade company of the world, if you have the classical shade guide, honestly, guys, pitch it. Get one of these. It's called the Vita Linear 3D Shade Guide. This is going to change everything for you. Why? Because you're not going to have remakes. So a really quick lesson for you on how it works. This top tab here, it's called your value tab. So what you do is you go from dark to light, and you try to find the lightness or darkness that closely matches with the tooth you're trying to match. So in this case, the value is 2. What you do is it's a 2-step process. The second step is you find a second card. And that second card, you pick your final shade. And so you don't have to worry about what the numbers and letters mean. That's irrelevant. So in this case, it's 2L 1.5. So what you do is you send that to the lab, and they'll be able to reproduce it for you so that you have a much more accurate match. So there's no more remakes. Because the cost of remaking one crown, guys, do you know how expensive that is? It's not just time, but money, stereo costs. You've wasted so much more for effort. So why not do it right first time and one time? So the evolution, let's say for example, we're in CAD-CAM, and a lot of us are doing CAD-CAM. Materials have changed too. So because Vita has a patent on 3D shade guide, guess what? They also are the only company that actually has 3D master blocks. So that case I showed you where we're doing tooth number 37, or in the States it's tooth number 18, let's finalize it. So we have the crown designed, we pick our 3D shade, we pick our block. Vita's entire lineup of blocks, yes, they're classic shade guide, but they also make the blocks in 3D because it makes sense. So in this case, I'm gonna pick a block called Vita Supremacy. It's like Emax, very strong, over 500 megapascals. And you insert it, and again, it blends right in. And that's why I love 3D. It just makes sense. When you want a gradient of shade, there's a couple blocks that have this gradient where you can actually, instead of having a monochromatic block, you can actually have that transition where you have darkness at the cervical and a little lighter toward the occlusal. Pick your final shade, pick your block. You can actually move that crown within that block, depending on where you want that gradient, and you insert it and it blends right in. At a different angle, you can see, you know what, the shade technology is phenomenal. Let's talk about time, okay, because time is money. And I'm not here to talk about the different properties between different blocks. And I'm not here to knock any block either, because you know what, I use a lot of blocks. Emax is one of them. It's a phenomenal block. But let's talk about time. So Emax, when you actually have to process it, you have to put it in the mill and you have to put it in the oven. So depending on the size of the block, it takes about 28 to 43 minutes to finalize your restoration. Versus a block like a Namic, you put it in the mill and then you hand polish it. So it takes 13 minutes at the maximum, which means there's a difference of an average 22.5 minutes per restoration. So if you think about that, based on $400 an hour, the average dental production, you're saving or making $157 per restoration. So when you put it back in this chart here, the average dentist doing the average number of crowns, you're adding in $19,000 a year, guys. If you do 20 units, 37,000, 40 units, 75 grand. And for those of us who are more efficient, guess what? We make more. And just remember, this is doing the same number of crowns. All you did was change materials. Why? Because you saved time. A different way of thinking. Okay, so this is another case. And Dr. Sumner's gonna laugh at me because every time I show a case. I'm always a master of tooth number 22 or tooth number 10. So this is a case that I saw maybe a year ago. And in this case here, even though it's not, I guess, a great picture, there is enough barrel here, guys. So I didn't have to pull the tooth out. I didn't have to worry about doing endo. There's enough barrel to be able to crown this tooth. So it's a bad picture, so I apologize. So before technology, before I had CAD/CAM, what would I do? I had half an hour of time. So what I would do first, I put a couple pins in, build it up with a composite. I bring the patient back, a second appointment to do a crown. And I bring the patient back a third time to insert the crown. So based on an hour and a half total time, I'd bill $1,500. So you're billing about $1,000 an hour. But what if you could do all of it in half an hour? So what if you could put pins in, build up core, prep the tooth, and let technology do the rest? If you could do that in half an hour, you've just now tripled your efficiency. So you go from here to here in half an hour. Because after I prep it, guess what? The prime scan, because of its advancement in its ability to design very efficiently, can do it in such a short time. You take material technology like dynamic, that's also has that shade gradient, but also its time-saving capabilities of doing it in under 13 minutes. Plus, you have 3D shade technology. So when you combine technologies, this is what you can get in a short amount of time. Again, I'm not, this is not just me. It's using the tools that you have to their fullest capabilities. So when we talk about predictable, practical, profitable, number one, guys, I encourage everybody to buy that Vita 3D Shade Guide. And if you're in CAD/CAM, you know what, for me, I use a lot of blocks, but doesn't it make sense to be able to have blocks that also match this 3D shade? Something to think about, because if you have to remake it because you picked the wrong block that doesn't match the shade, all of a sudden you're doing it again. Let's take a side step, the implants. This is what I love doing. This is what Azim, Steve Dana, Steve Chang, this is what we all love doing. So let's talk about this. So Sham, you can answer that, ask that last question. That'd be great for the group.
Alrighty, so we've launched the poll. So please go ahead and answer. And then once it gets to about 60% of the people that have voted, we'll go ahead and end the poll, and I'll be showing everybody the results. All right, we'll give it about another 5-10 more seconds. All righty. And I'll be sharing this now with everybody. So, which statement best describes you? Please check all that apply. The majority, 57%, stated that they restore implants, followed by 44% stating that I want to learn how to place implants. And then at 38%, I place implants. And at 7%, I don't want to learn how to place implants.
Awesome. Okay, perfect. All right, guys. Sorry, Sham, I don't know how to get rid of this off my screen. You guys see this on my screen too? Or no? Okay, perfect. Thanks. Thanks, Sham. Okay, so let's talk about the evolution of a different kind of technology, abutment technology. So once again, we're going to talk about how dentists think in general and how should we think. I want to change your mindset. So this is my workflow, okay? And the point behind how you should think and how we think, just because someone like me or someone like Steve Dan, Azim, whoever is going to speak, doesn't mean that you go ahead and just adopt what we're doing. What I want to show you guys is to understand what it is I'm trying to do and to be able to take that and use your own tools in your own workflow and see whether or not the way that you're doing things can be more efficient. I'm not here to try to change your materials. I'm not here to try to change your techniques. I'm just trying to open your mind to looking at things a little bit different. Okay, so that's the goal. So even though I'm going to show you something in terms of my workflow, it doesn't mean that that's what you should do. So this is my workflow with digital abutment and CAD/CAM technology. So Atlantis is a company that customizes abutments. They make and they make abutments for all implants. So whether or not you're having a titanium abutments, zirconia abutments, for my way of doing things, I do what's on the screen here. I have a titanium abutment with a gold hue. So you get the best of both worlds. You get strength and you get aesthetics. And I want to show it to you in the digital world with Vita Superinity blocks. So try to understand what I'm doing, guys, so you understand why I'm putting these technologies together, or how I'm looking at this a little differently. So I placed an implant probably a year ago, and I'm ready to restore it. I use the scan body called Atlantis IO-Flow. We insert it, we scan it with a prime scan, and what do? I send it through a portal called Sirona Connect. You can send it to Atlantis directly, or in my case, I send it to my lab, because my lab, I'd rather have them deal with the parameters, okay? Because I don't want to have to work and waste time with Atlantis directly. So this is what I get 24 hours later. It's a digital virtual design of the abutment. So it comes back to me, and my lab knows my parameters, so, you know, hey, if it doesn't work out, they can redo it themselves. But I get this, I import this into my prime scan. See that blue line around the abutment? That's your margin. It's already marginated for you. At the bottom there, you see that green check mark says okay. I hit the okay, and guess what? The crown's designed. I tweak it for like a minute, and I'm ready to make it, I'm ready to mill the crown. So I'm gonna show it to you using Superinity. Why do you use Superinity? Because it's strong. Like I said, it's as strong as Emax, over 500 megapascals. Also, it's 3D shaded, right? I have the crown made before the abutment actually comes back. So what do I do with it? Well, I stack it. And the reason why I use Superinity is the only crown you can actually see through, so you can see where the hole is. And so guess what? I carefully drill the hole, because I want a screw-retained implant crown for everything, right? When you do digital, there's no distortion, so everything fits perfectly every time. I fire the crown, insert it, everybody's happy. So let's take it a step further. I want to show you why the technology has evolved and what makes sense. So sometimes, and this is another implant I place, sometimes, you know what, you think you place in the right spot, it's in between those two teeth, but you know, maybe it's not in the right spot. The implant probably should have probably been more mesial, because that 7, the second molar, is tipping in the way. And so when I get the abutment back, this is what I get. So what you're looking at here is you're looking down that screw hole of the implant, or the abutment. And if you actually put the crown on top, what you're doing is you're actually in the most distal aspect of the crown. So with Atlantis, Atlantis can actually design the abutment. And again, it's customized. They can design the abutment that you can have what's called an angulated screw access. So you can actually have the access channel more mesial, or more towards your occlusal, so you can access your screw so it's not toward the distal. And so if I'm cutting the hole, it would normally be here, straight on. It's too close to the distal. So I'm cutting the hole here. So when it's all said and done, look at how everything stacks. When you have digital technology, look at the margins where the crown meets the abutment. It's perfect. If I were to cut the hole here, again, this is the most distal aspect. It's too close to the distal marginal ridge, the crown will probably fracture. But because I want to be able to put technologies together, I create the efficiencies, I use technology to my advantage, so at the end of the day, I still have a screw-retained implant crown. Once again, guys, we all learn from our mistakes. You know what? And I'm here to show you my mistakes and say, you know what, this tooth or the implant should have been placed more mesial. We all learn from our errors, right? And that's what we want to show you guys. The next evolution is, and what I've been waiting for the past couple of years, is how do you combine Atlantis technology with CAD/CAM technology when they actually have the blocks that actually have those holes that are pre-drilled, so I don't have to drill myself. We're still waiting, apparently. All right, let's move on to implants. Implants have also evolved. Implant designs continue to evolve over time. This is what I use, and I still use. It's OsseoSpeed TX made by Astra. It's a great implant. Everybody here who places implants, and I think that 30% place it, which is great. You have your own brands and you have your own rationale for why you use those brands, and they work in your hands. I'm not here to knock any implant at all. But the flaw with most implants, including Astra, what I use, is that you have this internal hex. And when you have the internal hex, and think about this, if you're actually not to get screw-retained crown, because let's say you can't, and you have to cement retain the crown, think about this. When you put your abutment on, you're putting your abutment on, and it's gonna go in one of 6 different ways, right? And then you put your final crown on top. So with one crown, it's pretty straightforward to be able to figure that out. But what happens in a case like this? What happens when you have 6 implants, 6 abutments you have to place in a specific way? So what this is, it's called conus. These are customized abutments designed for a full prosthetic on top so that the patient, even though it's removable, it acts like it's fixed. And so in this case here, you have to place these abutments on in the exact position relative to one another. And if one abutment is turned 1/6 of a turn off, the whole thing doesn't work. Do you know how stressful this is to be able to transfer this from the model to the mouth? Even though they may have jigs, you know, that allow you to be able to transfer easy. Sometimes it's not that easy. This is a very stressful half an hour for me. But then a couple of years ago, the implant of Astra changed its design a little bit. And I didn't realize it at the time, but there are certain abutments that the Astra EV, it allows the abutment to only engage in one position, not 6, but 1, which is fantastic because now all of a sudden you have a similar case with 5 implants and I have to transfer this to the mouth. Because all these abutments only go in one position, guess what? I'm not stressed. I transfer this from the model to the mouth in minutes. So when you talk about this change, this slight change in the design, all of a sudden it affects your time. And so you have a 5-minute of no stress versus 30 minutes of stress. I'll take the 5 minutes with no stress any day of the week. And so for guys that do cases like this, we're not charging $400 an hour. We're in the thousands per hour, right? And so that 25-minute difference in doing multiple cases over the course of a year, it really adds up. So look at the design of your implant. And as things evolve, understand what the evolution designs are and use it so that it can be more efficient in your own workflow. Let's take another step of CBCT. So how many of you guys have cone beam? So I say 24%, and then most don't. And I'm gonna guess 24%, most of that 24% places the implants. So cone beam is all about perspective. So here we see Prince William. You wonder whether or not he's upset at something. But from a different angle, different perspective, and this is from Dr. Mona, shout out to you. This is the other perspective. So cone beam is all about seeing things from a different angle, different planes of view. So why do we use cone beams? We want to be able to see where specific structures are. If there's a crack, is there one? Where does it propagate to? Can you restore the tooth? Lesions. On a pan or a PA, we see mesial-distal volumes, or we see the dimension of the mesial-distal, but we can't tell where the buccolingual dimension is. One perspective, patient comes in with pain. Is it because the endo needs to be retreated? Is it something in the periodontium or not? Take another angle, another view, and all of a sudden the story changes. Let's talk about cone beam as a tool for surgery. Let's talk about aids. So there's probably quite a few people in the room who I've had the pleasure of teaching surgery to, and this is a pretty straightforward case. It's a 17-year-old Caucasian female, slim built, conical roots, piece of cake, right? And so let's say we're talking about tooth number 4A. What we talk about, incision, flap design, elevate the flap, move a little bit of bone, the tooth should come out in seconds. It was 10 minutes later, I couldn't make that tooth move. And I finally got it out later on, and all of a sudden, this is what it looks like. And it's curved toward the buccal. Okay, so in hindsight, if I had a cone beam, would it have changed my approach? Absolutely. So for those of us who are newer to surgery, or even those who are doing a moderate amount of surgery, I probably say, if you have a tool to use, take a cone beam to see the curvature of your anatomy. It's a huge advantage to be able to have more information. Let's talk about ortho. In my office, my business partner, Dr. Manny Chang, does a ton of ortho. And so we see a number of these cases a year where tooth number 2-3 or tooth number 11 in the States is impacted. And so what do? We take a cone beam. So we take an axial view on the bottom right side. And what do? We measure it. So we measure from a reference point, let's say from the contact point of the central and lateral incisor to the mid-lingual of the canine, we measure it. And so we basically transfer that to the mouth. So we measure it, cut the hole, drill a bit of bone, there it is. Put the bracket on, it's 8 millimeters, guys. Put the bracket on, chain on, and then it goes right back down the hallway, and Dr. Chang finishes up the case. Then we have something called GPS guided surgery. Very, very cool technology. We take a cone beam with the patient, and this is for those who like the idea of doing freehand surgery with the advantage of having things done guided. So a company like Navident, there are other companies like this, where you actually have these tags. The patient wears a jaw tag, and you have a certain tag on your drill. And you also have a stereoscopic camera. So what happens is that the camera recognizes the relative positions of the drill tag and the jaw tag, so it knows exactly where the tip of the burr is in relation to the hard tissues. And so what you do is you take the cone beam and you design the crown and the implant in the software. And I did this in conjunction with doing a sinus lift. And so after you plan the implant where it's going to go, and here I am with my full PPE on. Don't ever show this to anybody, guys. Things have changed now. Okay, so this is what we do. So this is what you're looking at on the computer screen as you're doing the surgery. And so the idea is like a video game. You have this bullseye on the left side, and you're basically trying to hit the bullseye. And you see all the 3 different planes of view. And the idea is to be able to angulate the implant or the drill compared to where you planned the implant. And it's very, very accurate. It's amazing what it can do. So something for anyone who's thinking about guided surgery, but doing freehand, this is definitely a great way to go. Let's talk about fully guided surgery or fully edentulous guided surgery. So one last big case. This is a case that I'm proud to say I did with my 2 colleagues, 2 friends, Adam McCabe and Mark Shan. Big shout out to you guys. These 2 guys are at the forefront of digital dentistry and denturism and lab technology. So we're going to show you a case that I believe we're the first in Canada to be able to do things fully digital from start to finish with Prime Scan. This is a patient. She has her transitional dentures in. She wants to have full arch implants, full arch restorations. We 3D print the dentures. And the reason for 3D printing it is that, oh, sorry guys. You actually can try it in. The patient can actually try it and wear it and test drive the appliance. So they can actually try the aesthetics, the phonetics, the ability to chew, bite, all that stuff. And if they don't like it, you know what, Mark or Adam, they just tweak it digitally, print another one, and they try it again. And when they're happy with it, fantastic. Then what do you do? Then you take these radiographic markers. For those of you who watched Dr. Steve Diana's talk yesterday, this is what he was talking about. You put these markers on the denture, and then you take a cone beam of that denture all by itself. And then what you do is you have the patient wear the denture, and you take a second cone beam. It's called a dual scan. And what do we do with that? We basically use implant planning software to design the position of the implants based on the final restoration. Okay, that's really important, guys. Okay, you want to make sure you have the prosthetics figured out first before you place the implants. And then we have our surgical guide, 3D printed. You do your surgery, you flap it, you seat it, you got to make sure it's seated, and it's a guide for a reason, guys. Sometimes this doesn't work, especially if you're off by a hair, it's going to be off. For those of you who haven't seen guided surgery before, I'm not sure if anyone's seen it live, but this is kind of what it looks like. So the idea is you have a guide, and you have this little recipe sheet, which actually tells you which guide drills to use in which sites. And so you're using probably like 3, 4, 5 different drills for each osteotomy site. Everything will fit like a glove. You basically bottom out each drill based on the ones you've chosen to use for each osteotomy site. And by the end of it all, you're basically go through a sequence in like a minute. So within literally 10 to 15 minutes, your entire surgical design's all done, and you can place your implants. And this is what it looks like when it's all done. 4 months later, imagine taking polyvinyl siloxane. Imagine taking just an upper arch of 6 different implants. Just imagine what happens if one were to ever distort. Not good. So with digital, this is what we do. The same scan bodies we basically insert. And we take a scan of the upper, lower arches. And then how do we reproduce the bite? So we use this. So this is actually pretty ingenious. So Adam and Mark came up with this. And what it is, it's basically the 3D printed dentures with windows cut out. Okay, so why the windows? For this. The patient is actually wearing the dentures. The patient's in occlusion. So the patient feels like everything feels normal. But now you can actually scan those abutments or the scan bodies in relative position to each other. So you know exactly where the implants are with respect to each other. So you can reproduce the bite, the vertical, all of it. And so this is what we do with the prime scan, and then I send it via Sirona Connect. I'm not sending it through a lab, I'm sending it right online, and they get this a minute later, right? They import that into their system, and they start designing. So designing the abutments based on the final restoration. Everything's supposed to be parallel based on what we decided on conus. We use the MCX5 to be able to, I guess, mill the final prosthetic. And this is Mark Chen's amazing work with Adam McCabe. We insert the prosthetic, everything fits like a glove. All right, let's talk numbers now. So how many of you guys have a cone beam? 24%. So I want to show you how it can make sense to buy, let's say, this cone beam. This is the one I have. And the reason why I have this is it actually works with my prime scan. We talk about how everything's supposed to be fully integrated, right? So this makes a lot of sense. But the problem is that this is one of the more expensive cone beams. But I want to show you how this makes sense to anybody if you want to invest in something that costs this much. So the rule of ROI, 3 to 5 years. Once again, we talk about the cost, okay? I want to make a few assumptions. I want to assume that every single person in this room works in Toronto or Vancouver, the worst possible place to work, which means that you don't have a big patient base. You don't have 1,000, 2,000 patients, you have 700. Unless you're taking a pan every 5 years, which is probably a very reasonable time frame. So at current values of $65 a pan, this is what it equates to over 5 years. So you basically deduct that cost in order to be able to understand what the difference is. So in terms of cone beam usage, you have to come up with that difference of $74,500. The cone beams, the fee is $300 to $400 depending on the size of the volume you're taking. To interpret it, you have to send it to a radiologist or a company like Canary to be able to interpret it. If you want to do it yourself, by all means, go for it. To me, I don't have that time to be able to do that. I don't want that responsibility. So at the end of the day, your net fee is $250 per cone beam. So based on that, you need to take at least shy of 300 a year. Sorry, 300 total over 5 years, which equates to just over 1 a week. Okay. So for the 24 of you who have cone beams, you're probably placing implants. Once again, how do we think? We all think that people that buy cone beams are the ones that place implants, right? Maybe there's a different way of looking at things. So think about this. What are the indications for cone beams? And I'm just gonna give you a few of them. Lesions, we talked about that, and PAs or PANs. When you have a lesion, take a cone beam. You can see the buccolingual dimension of it. It's just more information for you. Whether or not you're gonna deal with it, whether or not you can send it to a specialist, it's more information for someone else to look at. Surgery, we talked about tooth morphology. For those of you who are wanting to do more surgery, it's always better to have more information. Take a cone beam. Cracked teeth. How many times do you see patients who have pain that's cracked and they have issues and you don't know where it is cracked or not? Take a cone beam to figure out whether or not that's something that can be diagnosed. TMJ concerns. Take a cone beam, even if you're not treating the patient yourself, it's more information for the person you're referring it to. Position of structures, things like endo, curvature of the roots, or even how many canals that tooth has. And orthodontic therapy is becoming more apparent and also with airway. But for the most part, for all GPs, this is our bread and butter, everything in between. So do we see situations where we're taking one of these cone beams once a week or more? Absolutely. We're gonna see this multiple times a week. So if that's the case, guess what, guys? You've made a return on your investment, 100%. Let's take a different perspective on things. If you have a cone beam, unless your colleagues around you don't, guess what? Let them know you have it. Instead of having them drive across town to the nearest center, they can just walk down the street or drive down the street to your office and you send it right back to them. It's a service you can offer to your colleagues. Just imagine if you had 5 colleagues that each one of them sent you one cone beam a month for one patient. Now all of a sudden you're paying your cone beam off in half the time. So let's put it all together. Okay, we're getting close to being done, guys. So let's put it all together talking about the traditional implant and crown workflow, doing everything the way we did before. So these are the numbers. in Ontario. Total fees $4,000. At the end of the day, your dental fee is at the bottom, $2,600. That's for the crown and the implant. The time it takes you traditionally, let's say you book an hour to do the implant, post-op check a couple weeks later. 4 months later, you torque test it or do ISQ values, take your initial impression, or a custom tray 2 weeks later for the final impression, and then your final insert with your abutment and crown, okay? So at the end of the day, this is your fee. That's the time it takes you total for the implant and crown, all the appointments. That's what you're making per hour. So now let's go digital. So with digital, now you have technology at your fingertips. You're making a guide whether or not you're 3D printing it or you're milling it. So now your fee's a little bit more. Why? Because you're taking the cone beam. But if you look at the bottom 2 lines, now you're making the crown yourself. You have your in-house lab fee. You're adding it to your initial dental fee. Okay, so now you're producing more. But on top of that, you're saving time. Because when you do things digitally and when you do things guided, your implant placement time is half an hour is a lot of time, guys, but I'm gonna say half an hour anyways, okay? Let's say a month later, you do a post-op check and you scan the patient, and then 4 months after the initial surgery, you torque test it, which it should be totally fine, and you insert. So based on the total fee, divided by the time, you've done the same amount of work and you tripled your efficiencies because you have technology at your fingertips. Let's take it a step further. Let's talk about fully guided surgery. Let's say per implant. At the bottom there, outside of costs, let's say you're taking home $1,500 per implant as your professional fee. And your time, as I showed you earlier, to do guided surgery, let's say on an arch, let's say it takes you an hour. I mean, I showed you it probably takes 15 minutes, but let's just say it's an hour from, you know, making the decision and doing your suturing. A week or 2 later, you do a post-op check, that's it. So based on your dental fees, divided by the time, guys, you know what? In 1 hour, this is more than what most dentists do in 1 to 2 days. So this is something that, again, it's not something that I'm doing. Anybody in this room can do the same thing if you understand how to use technology and efficiencies to its fullest capabilities. Okay, I'm nothing special. I'm just showing you what can be done when you understand how to use the tools. Once again, we talked about this. Okay, the cost of equipment. We can't justify the cost of the equipment because it costs so much. And a lot of you guys are saying this. I don't do that many implants, so I can't justify the cost. Or some of you are saying I don't place implants. And that's okay too. But once again, this is the secret. If you enjoy what you do, guess what, guys? You do more of it. Right? So for those of us who want to learn how to place implants, for those of us who are doing surgery, guess what? If you like surgery, you're going to do more implants. I guarantee you. We already told you that you don't even have to place implants and still get a return on investment. Even if you had your colleagues refer cone beams to you, you're going to pay your return on investment off in half the time. Let's take a different perspective of things. So let's say you don't place implants and you want to learn. And I think that Sham said 44% of you want to learn. And let's just say that you want to buy a cone beam and a scanner. Okay, so this is how the numbers work. If you can take 5 cone beams a month, just the profit alone from 24 implants, that's basically 4.8 a year. Just the profits. Okay, the profits alone will pay both cone beam and your scanner, in this case, the prime scan off. And just to kind of give you guys perspective, 4.8 implants per year. I mean, I think Azim, Steve, Diana, you know, these guys, I mean, they probably do, you know, at the minimum 5 a week. And some days, many days, they're doing 5 to 8 a day. So 4.8 a year is a very difficult number to hit because it's such a low number. And let's say there's some of you that also said that, you know, you don't want to learn, and that's okay. Because, you know, we have to do what we enjoy doing, right? And if you don't enjoy doing surgery, by all means, don't do it. So let me show you something. Let's say you don't want to learn implants, but yet you want a cone beam and you want a scanner, let's say like the prime scan, but let's say you also want a mill too. So how do the numbers work? So let's say if you did 10 crowns a month and you're the average dentist doing $400 an hour and you took 5 cone beams a month, you could pay all this off in 4 years. Okay, this is the math, this is the numbers. And if you do place the implants, guys, you know what? Sky's the limit, okay? My hat's off to you. Last but not least, digital ortho. And I'm not going to talk about this much at all. I'm just going to leave you with a little bit of a cliffhanger right here. So this is Dr. Jeff Sumner on the right. And you know, our friend in the middle, you know, of course he needs ortho. And we saw Mr. Powers the past couple of years at the Chicago Midwinter. So he's a rising star in our photos all the time. So this is the last thought, guys. A lot of us do Invisalign. And some of us don't, but we want to learn, and that's okay. And I want to be able to kind of share with you something pretty cool. And Jeff on Tuesday is going to be able to talk about this a lot further and kind of share with you the secrets. So let's say, for example, if you did 2 cases a month, okay, this is a very conservative number. And with Invisalign, you basically send them your models, they send you back all the trays and everything like that. And so you basically profit based on the case. But let's say, for example, you're going to use a company called SureSmile. And let's say that you're doing the same number of cases. No more, just 2. But with SureSmile, let's say you send them your scan, and they're going to send you the STL files. So now you're going to take those files, and you're going to 3D print your own models. And you're going to make your own clear aligners. Okay? So what I'm going to show you, what Jeff's going to show you, is that when you are the average dentist doing $400 an hour, and you want to be able to invest in all this equipment. Let's say you buy a prime scan, let's say you buy a 3D printer, let's say you buy your machine that basically makes all your clear aligners for you. It's going to cost you probably over $100,000. Okay, so it's not cheap. But we're going to show you, or Jeff's going to show you, that just by doing 2 cases a month, and the difference in profits, not the total profit, but the difference in profit between SureSmile and Invisalign, that difference will pay all your equipment off, all $100 and something thousand off, at $400 an hour, only doing 2 cases a month, no more, and you pay it off in under 2 years. Okay, and this is not doing any crowns at all. This is just ortho only. So tune in next Tuesday, and Dr. Jeff Sumner is going to wow you with how this is going to make sense. So last but not least, where do we go from here? Right now, we're all staying at home, right? We're all waiting, we're all learning. Take the time to learn, guys. Take time to figure out what makes sense in your practices. I'm not saying go buy technology. That's not the point. The point is to understand how to look at things more efficiently and how to look at things differently so that you can actually better make decisions at your practice. Because sooner or later, all this is just going to go away. And we'll be back in our offices a lot sooner than we think, or hopefully. Remember though, success is the uncommon application of common knowledge. I haven't taught you guys anything. You already know the answers. It's just I'm bringing what you already know to the forefront. At the end of the day, guys, follow your passion. Find out what it is that you're excited about, enjoy what you do, and guess what? Do more of it, okay? So bottom line, how do we think? Try to find a way of thinking outside the box. Maybe there's a different way to think. And I hope that this helps you guys to propel yourselves for the future, because you know the future is going to be bright still. No matter what the situation is now, you have to think differently. So thank you guys so much for all your time and attention. Here's my email address. Reach out to me on social media platforms. And you know, down the road, if you're interested in other talks, if there's certain things that you want to know how I think, by all means, message me, message Dr. Shurgan, and I'm sure I'll come up with another course sooner than later. And don't forget to tune in with Dr. Jeff Sumner on Tuesday. Thanks, guys.
That was absolutely incredible, Dr. Kwek. We're just going to get you, if you don't mind, to stop screen sharing. And then I'll ask everybody, if possible, to go into gallery view. That way we can see as many of our speakers and panelists as possible. I think that's probably the most that I've ever had to work behind the scenes. I feel like, I don't know if you guys can see, I got a sweat built up or something. But thank you guys for all of the questions, and thanks everybody for joining us today. So we're gonna start out with a couple of housekeeping items. If you haven't typed in your name and your email address already, please go ahead and do so in the chat lines. This is just to receive some additional continuing education points as well, and to be a part of our mailing group. The other thing as well, if you want to sign up for our upcoming talks, including Dr. Sumner's talk on Tuesday at 12 p.m., please visit dtacademy.ca/webinars. And as we mentioned in the past for Mr. Vic Jindal's talk coming up on Monday, we have 2 talks, one at 10 a.m. and the other one is at 2 p.m. I did put the link on in the chat group. So please make sure that you attend one of those 2 talks. They're going to be very, very informative. For our previous talks, please visit our YouTube channels at Dentistry Disrupted. There's a couple of very cool talks from Azim Sheikh, Jake Carrier, Michael Rondinelli, Stephen Diana's will be posted up there as well, Manisha Jindal, and Steve Chang, and many, many more. I'm not sure who is screen. Let me just there we go. The other thing too, we're gonna go ahead and start with a couple of questions. I'm gonna have Manisha go ahead and get started with the first one.
Okay, so Azim asks, what is the best way to incorporate an intraoral scanner into your workflow? Is it best to train your assistant and have one room, etc.?
I think everybody looks at things differently. I know that for myself and Dr. Sumner, we like to be in control of scanning, especially when we're designing. And I think if you're scanning with the intention of a lab designing or scanning for ortho purposes or whatnot, sure, then it definitely makes sense for an assistant or auxiliary to be able to take care of that. I know Dr. Shurgan, he does things a different way. He has one of his staff actually scan and design. So it depends on what you're using it for. I'm not sure if I answered your question or not.
And I can just add to that, that it will depend on the volume in which you're doing. So when you sort of start out, you can, be the one to maybe dabble in it a little bit. And then as you move into potentially doing all your records with scans. So in our office, we do, everyone is completely scanned, beginning and end and middle, whether they are aligners or braces, it doesn't matter. So of course, we've got multiple people in the office that know how to scan. Basically, everyone's got to know how to scan. But in your case, I would plan to eventually train everyone to cross-train, knowing if that's the direction you plan to go in the long run.
I would agree, and I'll just add to that too. There's nothing wrong with delegating to your staff and empowering them. I think that's a fantastic idea, but we all know staff can come and go and times change. So it's important that you as the primary owner and user of that technology know how to use it.
Excellent, thank you.
Our next question is from Vishal. Vishal says, thank you for the beautiful session. This is amazing. Wanted to know which CAD/CAM blocks do you use for aesthetic restorations, or you send to the lab? Follow-up question, any better option for anterior bridge with CAD/CAM? Thank you.
Okay, so I'm going to start and I'm going to have Dr. Sumner finish it. So for me, based on this, in terms of when I first started, there were so many blocks out there and all the blocks were phenomenal. You have different companies making different blocks. The problem is that all the companies outside of Vita had the classical shade guide. And the problem is that their shade guide, let's say for example, using Emax, their A2 shade is not the same as the Vita A2. So it's a little bit lighter. So the problem is that when you finalize your restoration, it looks a little different than what you planned. So that's why I started switching to the 3D shade guide, because it made so much more sense. I had a lot more consistent results. In terms of the overall aesthetics, a lot of times you have to stain and glaze. And this is where Dr. Sumner now has the ability to show you some amazing things, because a lot of times it's not about just taking that stock block and making it fit or making it look right. Sometimes you have to do some artistry in there. And this is where Jeff will basically take over from this point. Jeff?
Yeah, thanks, Mian. I think it's a great question, and really, fortunately, I've been doing it long enough, so I've used all the different blocks in it, and it makes sense, and I'll know what I need to use. There are some simple rules that you can follow if you're trying to match something else in the mouth, which is what we're trying to do. Most of the time, the Vita system seems to make sense, because as Mian showed you, that will match the shade, the true shade that is there, and you're going to get that true shade. On the other hand, if you're trying to match a patient who has a bunch of PFMs in their mouth, well, then it's better off to use a material that has low translucency. Then I'm going to go to an Emax low translucency, because that's going to mimic their PFMs that are already in their mouth. Now, if we're doing a a large case, big aesthetic case where you're doing 4, 6, 8, full mouth reconstruction, you can really use any material you want because we're creating that uniformness that we want. So choose then in that case the material that you're most comfortable with and you're going to get the best properties out of. So there's no one answer, but it comes down to what is most comfortable in your hands, what makes sense efficiently. The Vita and Namic is an amazing material. Mian and I both love Vita and Namic for the speed, but I'm not going to do a full mouth reconstruction with Vita and Namic. It's what you're comfortable with and what kind of stain system you're comfortable with. But if I were starting out at this stage, I think Vita covers a lot of the materials, and they have the options for every different strength and every option. So Vita would be my go-to if I were starting dentist with CAD/CAM.
Perfect. Next question comes from Nicholas Yap. Hey, Dr. Kwek. I have a question regarding intraoral scanners and the recording of patient's bite. If a patient has an unstable bite or a collapsed bite, is it possible to use the scanner to record the bite, or are there other techniques that can be used to record it? Thanks.
Well, so far, I mean, absolutely. I haven't had an issue with recording a bite, even if it's extremely collapsed, because it can somehow register the bite in 3D. And sometimes it's amazing what you can capture with, I only know the prime scan, guys. So I don't know what scanners have what capabilities. All I know is that the tools that I've used, it is very accurate. And even if you have, let's say 100% overbite, and let's just say the patient is overclosed, you can't even see the lower teeth when they're biting, it can recognize how the posterior teeth meet. So once it recognizes both sides, it can put it all together. And Jeff,
and I would add on to that and say it will recognize tissue. I'm going to be showing some cool cases where I have cases that we're just talking about there, where we end up opening the bite a significant amount, and all done with my prime scan and well, some with my OmniCam previous too. But absolutely, it's not just the teeth that recognizes, as Mian said, it's recognizing the tissue too. And when you capture that, it will link it all together.
Thank you, guys. The next question is from Ashish. He asks, hi there, wanted Dr. Kwek to talk a little bit more on things that we should keep in mind while scanning a crown which is clasped buccolingually. And we can have, and Ashish is with us here. Ashish, if it's okay with you, I'm going to unmute you. So if you want Dr. Kwek or Sumner to go ahead and answer an additional question, the floor is yours.
Hi, Dr. Kwek. Nice to connect with you.
Hey, too. What's going on?
Good.
Good. So I'm not sure I understand your question.
Yeah.
So the question basically was the case you showed us regarding the crown which had a clasp on it.
Yep.
And we were preparing it and you drew a line on it. So right. Basically what does the software do? Just disregard the rest of it?
So basically you just draw a line of whatever part of the tooth you want to copy. And everything else, you let the software basically reconstruct whatever it thinks makes sense. So as long as the clasps, or as long as the partial is not touching the parts that it has to design itself, then it's reproducing what you've drawn the line around.
Okay.
So you're using a biocopy technique, which means there are certain parts of that tooth that you do not want to change.
Exactly.
That tooth is designed to fit that clasp 100%. Those are the portions you do not change at all. You trust it, and when it mills it, you do not trust those. That will guarantee that you have that perfect fit of the clasp. The rest of the tooth, it can design and make it a beautiful design tooth with cusps, with grooves and everything, but the part where the clasp touches, do not touch it, trust it.
Okay. Yeah, because those are the cases which are terrible. I mean,
extremely challenging in using the previous technique, but with CAD/CAM, with PrimeScan, you will be a hero. Patients will love you.
Thank you so much, Ashish. Now I'm going to be bringing in Mark Chan to this one because, as you guys know, Mark is a leading expert with 3D printing, and the next question does apply to with 3D printing as well. So we thought we would go ahead and bring Mark in as well to help us with this one. So go ahead, Manisha.
Oh, the question? Sure. Yeah. What 3D printers do you recommend, and what do you use them for?
Cool, that's a pretty broad question. Everyone can hear me okay, guys? Is okay?
Yeah.
So it really depends on your practice. I'm a denturist myself, and a couple of my colleagues and a couple of clinicians. Myself, I use the Asiga Max UV 385. It is pretty conducive to chairside dentistry. If you are an ortho-based clinician, I would say that this printer is a little bit too small. It can handle ortho, but it also depends on your volume. So if you're a high volume orthodontic practice, then the printer like the Asiga Max is a little bit too small. Maybe you can move into something like a Formlabs or a Moonray Pro, which has a bigger platform. So you are kind of sacrificing the accuracy compared to the accuracy of a smaller printer. For myself, because I'm doing multiple things, surgical guides, temp, crown and bridge, dentures, for myself, I choose an open source printer that can print the most of the materials that are available to me as a Canadian. As we know, the materials are changing day to day, and Health Canada is quite different than FDA. And so I kind of need a printer that is future-proof in one sense, so that if a new material does come onto the market, like a temporary crown and bridge material or a denture material, I still have the capabilities to use my hardware to print it. So in a nutshell, there is no right answer. It's the right machine for your practice. My only advice is do the research and don't listen to salespeople, because they will sell you something that you won't be able to use. So talk to your colleagues, there's many on here, and ask questions before you buy, especially now. I hope that answers the question.
Thank you so much for that, Mark. That was great. Dr. Kwek and Sumner, anything else that you want to add with the 3D printer?
Yeah, I would say, you know, and you'll hear me talking about 3D printers a fair bit. That's kind of one of the big things I'm talking about on Tuesday. You know, 3D printers are amazing. I would buy one that is designed for dentistry for sure. You can get cheap ones on the market for anything and they will work, but you want to think about what you're using your printer for. And one of the big decisions is the size of the platform. How big is the volume that you can print? You know, I'm using Formlab, and this is, and when I talk about it, it's by no means promoting Formlabs, the Moonray. I think the Sprint Ray that is available is an amazing machine. That's probably one that I would be going towards because of the size of the platform and the abilities and the speed of it. The speed is one thing I will be talking about also on Tuesday. Now, you didn't hear it from me or from Mian or from Mark, but there's probably going to be some other printers coming out from Dentsply Sirona that won't be as cheap, but the capabilities of those printers or that printer per se will be unbelievable. But I think everything, as we know, is kind of pushed back because of the time we're in. But you can still, this is what I talk about, is that to buy a printer is probably a very, very smart investment. And from that questionnaire that you put out, Shem, I mean, very few people have printers, and they're missing huge potential in their practice if they don't have a printer.
Absolutely. Thank you so much, Dr. Sumner. The next question is from Ashfaq. He asks to Dr. Kwek, what is the approximate cost of the Navident unit?
You know what, I don't have one, and it's a big platform in the office, and because I do a lot of things freehand, it's probably another reason why I didn't invest. And I think it's about 25 or 30 grand. So it's not crazy considering what it can do for you. So it does make sense, but I think that for those of us who like doing free-handed surgery, that tactile feel, and this is what I love about it, because when you do guided surgery, you're drilling through a guide. And for those of us who have done guided surgery, you're basically heating the bone up when you should be able to cool it with a coolant. And so the guide, unfortunately, kind of prevents the coolant or the irrigation from getting to the site. And you lose that sense of tactile feel when you're trying to feel how dense the bone is. And that's the part about guided surgery I don't like. But when you do it with a Navident, you're freehanding it still. You're freehanding it with the ability to do things somewhat guided. So I love the aspect of that. And so I think anybody who's looking at doing freehand surgery, but doing things guided with a cone beam, the Navident's an amazing piece of equipment. I think they're still evolving. And I'm sure as time goes on, software, hardware may continue to change, but I mean, it's amazing. It's amazing what it can do.
would you recommend a dentist who is just learning how to place implants to invest in an Avident?
That's a loaded question. That's a hard one to answer. I'll be honest, guys. I think that number one, guided surgery is just that. It's a guide. Okay. And whoever is trying to do implant surgery, from myself, from all the guys who basically teach surgery, you need to understand how to do surgery first. You need to understand anatomy. You need to understand where you are first, because if the guide fails, if whatever it is, Avident or surgical guides, if they fail, you need to be able to do things the old school way, meaning that you have to visually look at everything and do it freehand. So even though technology is somewhat accurate, you can't rely on it 100%. I don't know if that answers your question.
No, I think it did.
But it's a great tool. Again, they're all tools, guys. Okay,
Yeah,
you have to use it as a tool.
Yeah, the point that I wanted to make too is that as a starting out implantologist or somebody who wants to place implants, I think it's there's a lot to say about learning how to place implants on your own first before getting a lot of these tools that will help, that will make things a lot more efficient and a lot better for you. I know that, Dr. Azim and Steve Chang and Steve and Diana would probably have something to say about this as well. But my recommendation would be to probably buy those once you feel comfortable placing implants.
Exactly.
Great. Okay, next question. Kate asks, how do you justify to a patient to pay $300 or $400 for a CBCT for an extraction?
At the end of the day, guys, it's all about providing the value. Okay, if you're able to let patients know that you're out in their best interest, and at the end of the day, they make the choice. If they don't want to, that's totally fine. But if you give them the value of why it makes sense, and you're not trying to sell them anything, but you're trying to give them the best opportunity, let them decide what they want to do. And so you don't have to justify anything. It's more or less giving them the opportunity to understand why the technology is available and what it's there for. And if they want to invest in that, then fantastic. And if not, then you have one less tool to use.
The next question is from Maher. He asks, which lab do you use for guided surgery?
I use Mark Chan and Adam McCabe. So basically, the lab that I used all the time was ADL in Toronto. Fantastic lab. And I still use them for a number of things. But lately, based on the guides that I've made, we do it with CCAT, basically incorporating the prime scan and the cone beam to be able to design our own placement. And so CCAT will send us the STL files, and Mark and Adam will basically print it for me, or I have a printer at the office too. But Mark and Adam are fantastic at that. And yeah, I mean, that's my workflow right now.
I can chime in on that a little bit. It's just make sure you talk to your lab, whatever lab you use, if they can do it. That's all. You want to keep that relationship going with your lab, but you need to make sure that the lab can do it. Even though they tell you they can do it, you need to know if they can do it or not. That's all.
Yeah, great advice. Next question, Marvin asks, does Invisalign accept scans from PrimeScan?
No. So this is the problem. So, and this is what I think Dr. Sumner is going to talk about on Tuesday, I think. So Invisalign accepted from the Omnicam, and there are a lot of new scanners on the market, PrimeScan included, that it doesn't allow it, you can't send it to Invisalign, which is in one hand bad for those of us who want to use Invisalign, but the other hand, you're going to see on Tuesday how it's such a great opportunity to open that platform to other companies that can do things probably in a much more significant way for your patients and for you as practitioners.
Well said, Mian.
The next question, thank you for that, Mian. The next question is from Hussein. Hussein asks, his question is, can you ask Dr. Kwek how he recommends a newer dentist not familiar with digital technology or techniques to get into the digital aspect of dentistry? Basically, where do we get started?
Okay. So I'll be honest, I think the easiest way or the best way to be able to learn and to see whether or not it can make sense and to understand the workflow, watch somebody. Don't shadow someone who actually does it. And I know that with our academy, with Dr. Shurgan, myself, Dr. Sumner, we have a lot of young dentists come and actually shadow us and actually see exactly what we do and understand the workflow. And we can kind of point out our little tips and tricks along the way so that you can decide whether or not it makes sense for you. So I think my advice is shadow somebody who's doing it. Shadow somebody who you feel is at a level that you want to learn from. and, you know, take it from there. And I know Dr. Azim Sheikh, you know, Dr. Steve, Diana, I mean, we all are open to opening our practices up for everybody to see what we do and to help our colleagues. And it's part of us giving back. That's what we want to do now.
I'm just going to pipe in here for a sec, because that's a great question. And I think there's a lot of people that are in that same boat and realize that they want to get into it. There's also a lot of people who have just bought a Cerec system or a CAD/CAM system for that, you know, it doesn't matter what system, and bought it maybe before all this came down, and are going, now I'm sitting here and I'm not learning and I'm missing the boat. So the opportunity is out there, and I'm in discussion with Dentsply Sirona, and we're actually setting up a number of webinars on Fridays to go through this, where we're doing basically online basic training. And then what I will do is release, starting with some simple cases where you can remotely design and go through the design of a tooth in your own house and in your own computer. You can't mill it. And then I will come on, whether it's an hour later or a day later, and I'll go through the tricks and the tips that I use when I design a crown, an onlay. Then we'll go into a single anterior. Then we'll go into multiple units. Then we'll get into, you know, where we're doing bridges, implants, screw retained implants. So we'll get into more and more complex. So while we're sitting around during this COVID time, you can be practicing and learning those skills to use your Cerec to the greatest of your abilities. So when we get out of this, you already have those skills in place. So that's a great way to learn, and you don't have to invest, and you'll find out if it really is for you.
And Julie Frey just had a wonderful suggestion. She said, I have my prime stand at home in my dining room. If anyone would like to contact me and do a demo virtually, happy to help in your downtime.
Thanks, Julie. Awesome. Thank you, Julie. If you want to hear about the next evolution of digital dentistry, make sure you chime in on Tuesday at 12 p.m. to see Dr. Sumner talk to us a little bit more about what's to come in our profession. Thank you guys all for attending today's talk. We really, truly appreciate you guys for spending the time out of your busy Friday to get things, to come in and spend it with us. From the bottom of my heart, I would like to thank all of the speakers this entire week. Azim, Kayvon Abazadeh, Steve and Diana, Mian, and obviously all of our previous speakers as well, from Steve Chang, Goth Su, and Manisha Jindal, and everybody, and Vic Jindal, and everybody who's attended our lectures, and everybody who has offered us the time and the effort to go ahead and put together these wonderful presentations and give this back to our communities. Just a full disclosure here, nobody's getting paid, nobody's getting incentivized whatsoever to do these talks. And it means a lot to us, and I see it from the text that I get on a daily basis of people just absolutely thanking us for what it is that we're doing. And I just wanted to express our sincerest gratitude and appreciation for you guys taking the time and spending it with us and passing your knowledge on to us. And for those of you guys who know Manisha, Jeff, Mian, Steve, and Azim, and everybody that's been part of our talks, as you guys already mentioned, it's a simple phone call, a text, an email, just to go in and shadow these guys. These guys will open up their doors to you and give you the entire world. So please don't be shy to reach out to any one of them and ask any questions that you may. And once again, thank you guys so much for attending our webinars. We look forward to seeing you guys on Monday for the much anticipated Vic Jindal talks at 10 a.m. and 2 p.m. 2 p.m.
Yeah.
At 2 p.m. And also to see our very own Dr. Jeff Sumner on Tuesday at 12 p.m. Make sure you visit dtacademy.ca/webinar in order to sign up for the talk. Thank you guys. Have a safe and wonderful weekend, and enjoy your day.
Thanks, everybody. Thank you.
Bye.